know me, I think I know everyone in the room, but for everyone online, I'm Jordan Arabeck. I'm director of the Adult Congenital Heart Disease Program here at Phoenix Children's. And it's really my pleasure and a privilege to introduce Dr. Jonathan Menachem to give grand rounds today. Dr. Menachem is a good friend of mine. I was doing the math last night and known each other for just shy of 20 years. So not quite 20 years yet. But Dr. Menachem did his medical training. He went to medical school at Tulane University and then completed an internal medicine residency at Duke University. And after that, went to University of Pennsylvania, where he completed an adult cardiovascular disease fellowship. And after he completed his adult cardiovascular disease fellowship, he really carved out an area for himself and tailor-made his advanced training combined in adult congenital heart disease and advanced heart failure and transplant, and really focused in on that area, which I think for a long time has been lacking in our subspecialty area. And I think anyone who does adult congenital heart disease does some heart failure, does some transplant, but not everyone does it well. And he said, I really want to do this and do it well and figure out how do we get these patients surviving into transplant and surviving transplant. So once he completed his training, he started at Vanderbilt, where he's now an associate professor in the departments of internal medicine and pediatrics. He is the director of the congenital cardiac therapies division and associate director in the heart failure and transplant division. And he's really can be credited with really starting their adult congenital heart transplant program and building it up. And in a relatively short period of time since he's been there, has turned it into a national referral center and an expert center in adult congenital heart disease transplant. He's really one of the world experts now in adult congenital heart disease transplant. He's written extensively on the subject. He's frequently requested lecturer. And it's really, again, a pleasure and a privilege to hear him today talk about transplant in the adult congenital heart disease population.
It's always a little scary when your good friends from a long time introduce you. You don't know where that's going to go. That was really nice. Thank you. So thanks for having me. I'm going to talk to you about this intersection between adult congenital heart disease and transplant. Here are my disclosures, and I do have to tell you that I'm pretty excited to be here because we're doing this in person. And when Dr. Franklin calls you and asks you to give a talk, it's kind of a big deal. So I'm really excited to be here. Thanks for having me. I'm just going to talk to you a little bit about how I got to where I am. I grew up in New York, which also you should know, I talk with my hands and I walk a lot. So if the Zoom people can't see me, someone text, I guess I'll try to stay still. And so I was a Duke undergrad, and then I did investment banking and decided that wasn't for me. And then I worked for a medical device company as sort of a bridge to going to med school. But somewhere along the line, I've read this book called A Walk on Water about Roger Mee as a surgeon at Cleveland Clinic and what they were doing for pediatric, for kids with congenital heart disease. And so then I got to Tulane. Jordan and I were the first class right after Katrina, which was quite an interesting time to be in New Orleans. And while I was there, I did my pediatric med school time at Ochsner. And so Ochsner had probably the biggest congenital program at the time. And Doug Moody, who we were talking about at dinner last night, was one of the people there who said to me, if you're really interested in both adults and congenital, then what you got to do is you got to go to Emory and work with Wendy Book while you're a med student, because she's doing adult congenital heart disease and sort of one of the experts in our region. So I went there, and Wendy had also done transplant. So this sort of got the bug in my head. And long story short, so I go to Duke, where I worked with Tom Bayshore, who is credited for training a lot of, Wayne was there, a lot of Anne-Marie Valente, Joe Kay. There's a whole bunch of leaders that have come through Duke. And then I went to Penn, where we sort of carved out this niche of combining adult congenital heart disease and transplant. And I think this is more geared towards residents and fellows, but my goal was to do adult congenital heart disease and know a lot about heart failure and transplant. And one of my mentors at Penn was Marielle Jessup, who at the time was the president of the AHA. And she told me, you're doing this wrong. She said, there's a lot of people in adult congenital heart disease that are interested in heart failure and transplant. but there's very few people around the country that are in heart failure and transplant as their primary focus and are trained in congenital heart disease. So we sort of revamped everything, and in 4 years I did both training, and now I'm at Vanderbilt, where I am in the adult transplant world, but I focus on failing congenital patients. So that's sort of a long way to tell you how I got to where I am. So let me just tell you, I like to start, you guys all know this, but from an adult side, I always find this fascinating. When you look at congenital heart context, is that in Osler, right, the big principles of medicine, there were essentially 4 pages given to congenital heart disease, which essentially said there's nothing to do, they all die. And now, as you all know, this is the fastest growing segment of adult cardiology. So there's 20,000 new patients per year that are coming to the adult side with congenital heart disease. And there's actually more, there's more adults, right, with congenital heart disease than there are kids. So it's a fast growing area. The problem we're finding, though, is that now the number one cause of death for adults with congenital heart disease is heart failure, but they're not undergoing transplant. We're going to talk a little bit about why that is and how we fix this. So when I got to Vanderbilt, part of the way I got to Vanderbilt was Mariel Jessup's closest friend is Joanne Lindenfeld, who at the time was the president of the HFSA. And Mariel said to me, "You go work for Joanne in Nashville." And I said, "I don't know anything about Nashville other than it's known for country music, and I don't know anything about Vanderbilt." She said, "Go work there because this is how your mentorship and how we're going to get you to where you want to go." So before I got to Vanderbilt, in the 5 years before I got there, there were only 2 adults with congenital heart disease that underwent transplant. And so I sat down with Joanne, we sort of planned this whole thing out of, we got to fix this problem, because we know that that's not nearly enough. So we defined what our goals and how we were going to define success. So number one was we were going to figure out how to find all the patients. They got to be there, but where are they? Then we're going to figure out how to improve patient care, which is an ongoing problem, and then grow our research efforts. And then we're going to sort of figure out how to mix all of this together. Excuse me. So let's talk about finding the patients. That was the easy part. So when I got to Vanderbilt, I said, well, we're gonna start it in Nashville, and we're gonna look just at the Children's Hospital here. And that's where all of our patients are gonna come from. And turns out that's not actually the case. We've now had referrals from all of these different states. I'm partly here in hope of getting a red dot in Arizona, but what we found was there was a need, and that these patients were coming from all over to be evaluated. Right now, and I'll show you more of the data later in the talk, but we're evaluating between 2 and 4 congenital patients per week for transplant. So clearly that has grown. Then we got to figure out, though, how are we going to improve care? Because one of the things was that we looked at this, and Gabe Hernandez, one of our fellows, who's now at the University of Mississippi, was that outcomes don't tell the whole story, right? So when he looked at the NIS database, which you all know is not a perfect database, Jordan can go into why statistically it's all messed up. But what we know is that, well, that everyone says, well, congenital heart patients don't do as well. Well, a lot of that mortality is early mortality after transplant, and a lot of it is existing in the Fontan patients. And a lot of it, then one more step, is when we're getting these patients. So we said, all right, we got to take a step back and figure out, identify which patients are at highest risk and how we get patients safely through transplant. So I came in really excited. We're going to just do this. And this was the first patient that we did, a Fontan, who underwent heart liver. This is James. He was a hypoplast with PLE. His kidney function was sort of crummy, and he did awful. And he came out on ECMO after going back 3 different times for bleeding, and he subsequently died. And we think about James all the time, and I always start by talking about him because we learned a ton about what we were doing wrong and what we needed to do differently. And so we went back to the drawing board and said, all right, we got to rethink about risk. We got to rethink about surgical plans. We got to think about how often we're going to see them. And I'll show you what we've done. But the other major thing that we learned from James, and I won't read all of this to you, but when we talked to his mother after the fact, this was something that our team struggled with a lot, because they said, oh my God, look what we just did to this kid. He's, this has been a horrible death. And as all of you know that take care of congenital heart patients, these patients and families have been told, they're, at least from the era that I'm seeing them, they've been told they're going to die their whole life and they're not going to survive. So the patients and families, when they're feeling bad, they're willing to undergo this risk. And it's not like we're doing things to hurt them, and they're on board. So we said, all right, let's sort of revamp this to think about how we can do this. So we started by saying, all right, let's look at patients based on anatomy. And so it's nice when you give these talks to congenital folks, I don't have to go through all the specifics. But anyway, we started thinking about, all right, how are we going to look at them from a risk perspective based on anatomy, right? And I think this is important for centers to realize, is that when you think about transplant, as surgeons, I'm sure will tell you, like transplanting a tetralogy of Fallot is way different than transplanting Fontan with PLE that needs a heart and liver. So that was one thing we looked at, is how we're going to risk stratify them. And then we also looked at all the different risk factors about things that make them high risk going in. How does PLE work in here? How does sensitization? What's the role of pulmonary hypertension? I'll spend the rest of the talk sort of talking to you about how we've looked at some of these things. And then we had to develop the team to do this. And what's interesting is, so when I got to Vanderbilt, if you think about an ACHD patient, these are all the teams I could possibly fit on the slide, but it's all these different people, right? And all these different teams that have to take care of these patients. When I got to Vanderbilt, these were all there, which was nice. They just didn't have one lunatic who wanted to pull it all together. And so that was my role when I got there. We formed a group, the Advanced Congenital Cardiac Therapies, which was sort of a way of us saying, okay, we're going to quarterback this team and figure out how to get all of these patients to the right people and evaluated by everybody so that we can improve their outcomes. And then we want to focus on, so now going back now, how are we going to be prepared? And I start with this because we wrote an editorial about a paper, and you guys were probably involved in this, where they looked at Fontan patients in the pediatric population. And I think pediatric centers have done a way better job of collaborating and providing data across centers. But said, well, if you have a Fontan patient, how many of them need to see a heart failure doctor, right? So I would argue, and I think most of you would agree, that heart failure is the final common pathway for most Fontans, okay? So if we all know that they're going to develop heart failure, and they're probably a large number of them are going to need transplant or mechanical support, I would argue that it'd be beneficial for them to see a heart failure doctor. But in what you'll see here is that 45% said they don't need to see a heart failure doctor, despite we all recognize where they're headed. So if you extrapolate this to adults, it's even worse, because at least in pediatrics, everybody's been trained in congenital heart disease. In pediatrics, in the adult world, it's way different because, there's very few people outside of congenital that are paying attention to these patients. So I said, we got to get people around the country and around our region to focus on the fact that these patients don't fall off a cliff, right? Everyone always talks about, well, these congenital patients, they fall off a cliff. And what I would argue is it's all about knowing where the cliff is. So when we use this, I'm a big Austin Powers fan. So we use this steamroller reference, like, oh, the steamroller's coming, these patients are going to die. Well, it all depends on how far away you are from the cliff. So there's no really need to panic if you know what's coming. And so I think we need to be prepared. So how do we prevent the fall? So one of the things that we've done is we use a lot of cardiopulmonary exercise testing. And Sasha and the group up at in Boston when he was there has done a lot of work on this. And I think essentially what you'll see is that the patients that do worse, as you know, on exercise testing have worse outcomes or increased risk for death, transplant, or hospitalization. And what we've used is the change in exercise testing. I don't think the numbers on their own tell you the whole story. And so we'll frequently put our patients, as we think they're getting worse, even on the treadmill every 3 to 6 months, to see if we can pick off changes. And we don't just look in changes in peak VO2. We also look at, obviously, saturations. We look at slope, but we also look at time. Because time on a treadmill, if you were able to do 10 minutes on a Naughton protocol, and then 6 months later, you're only doing 3 minutes, that's a big change. there are barriers to this, and we looked at this when we were at Penn, is that one of the problems in getting patients referred to heart failure and transplant when we looked at barriers is that people will often say, well, we know the data in the adult world based on Donna Mancini's historic papers on, peak VO2 less than 14 or less than 12 if they're on beta blockers. So we don't want to send them to you until we reach those thresholds because you're going to say no. And what we showed here was that of our 20 patients at Penn, only one of those patients had actually met that peak VO2 number. So this tells some of the story, but it doesn't tell the whole story. We focus a lot on arrhythmias that we didn't always in the beginning. I hope I don't insult any of my EP colleagues, but the ablations are not benign, and we see this outside of congenital heart disease. Like, sometimes if the third VT ablation doesn't work in our cardiomyopathy patients, it's probably the fourth one's not going to work either. And so we got to start thinking about things. And this was a patient who was a repaired Glenn who was blue, who was listed for transplant, who underwent an AFib ablation up at Penn, one of the best EP departments in the country. And then she subsequently developed a TE fistula, tracheoesophageal fistula that had developed on the atrial cuff. So we transplanted her, she did well. And that one remaining part that was from the old heart that stays, a fistula developed and she died. And so this has sort of put us on a mission to say, okay, if patients are having worsening arrhythmias, we really need to use that as a warning sign that they may need transplant or mechanical support sooner. We like to tell people to plan ahead. And this is now a direct hit at my cath friends. But, this was a patient, we frequently, I think that the field has struggled in the past in that we didn't have options for these patients. And so everybody was always doing everything we could possibly think of to fix whatever we could. And now if we do have options like transplant and mechanical support, we have to think about what are the implications of everything we're doing. So this was a patient, this was a setting who had undergone a follow-up stenting of his superior limb, which we do, but he didn't get much better for very long. It was about 6 months. And I'll show you this. And this is what it looked like when they took all of this out at time of transplant. This young man almost had a catastrophic outcome in the OR at time of transplant due to the bleeding and the SVC issues that occurred in pulling all of this out. So it's something that has to be kept in mind. We're trying to look more at labs. High sensitivity CRP seems to be a pretty good marker of worsening. Although it's not perfect, but we don't know how to actually track it is the problem. MELD-XI, which is a combination of liver disease and end-stage and kidney disease, has been shown as a marker. It's interesting that this was the original data that they did up from Boston, and then the Boston group did another analysis and showed that they don't think that this impacts it. I don't know I don't want to use specific numbers, but again, when we start to see liver function getting worse and kidney function getting worse, irrespective of the number, worsening is a sign that we should be starting to think more about aggressive therapies. And then PLE, this is the first talk I've done in a while where I don't have to explain PLE, which is fantastic. So, what do we do about PLE? So, Kurt Schumacher, who probably most of you know, did this really nice analysis and said, well, PLE doesn't affect transplant outcomes. And I think that's true and it's not true. And Kurt and I have talked about this. On the pediatric side, that's probably true. So if you take a kiddo and transplant them because they're having really bad PLE, remember that age plays a huge role. I would argue that, so if you take a 10-year-old who's had PLE and you take them for transplant, they haven't had time to beat up the whole body. When we get referred a 40-year-old Fontan with PLE, that is a sick patient. And so we're trying to figure out in adults, how do we deal with PLE? It's interesting that that these patients are the ones that I always make sure that I meet in clinic and not just my partners, because inevitably, when they get, if they are seen by one of my partners will say, they look terrible. And I'm like, yeah, that's how they're supposed to. We got it. But my group is having to learn a little bit more about what a failing Fontan looks like and the spectrum. So what we've done is we've started to think about what are therapeutic options we can do to sort of fix PLE. So this was a nice paper that was done by Angela, who's now one of our attending, who was a fellow at the time. And this was all based on a Wendy book idea, where Wendy started from Emory, started putting these patients on midodrine. And so we looked at the patients we had done at Vanderbilt and at Emory. And what we found was, for a variety of reasons, maybe, which, it's all, I should say it's cytokines, it's all hand waving, but it's probably a combination of increased blood pressure, increased splanchnic vasoconstriction. I think it has something to do with alpha receptors on lymphatics that's been shown by the Michigan group. But what we saw was, in a number of these patients, when we were putting them on midodrine, their albumins would go up, their lymphocyte count would go up, and their IgG was going up. So we had seen a number of patients that we had listed that we put on midodrine, that their PLE got better, and then we delisted. And there's a couple of these patients that we're now following. So why is that important? Well, I think it's important because I don't think that those patients are not going to need transplant. They're probably going to need transplant at some point. However, on the adult side, taking a 30-year-old, first of all, if we can kick the can down the road and get them longer until transplant, it's better. But we're now able to say, okay, if we're going to take someone into transplant, we're now taking someone who's less likely to have a bad outcome due to nutrition or due to infection. And in fact, now we're moving up the pathway now, because we finally got mentioned, this paper got mentioned in one of the major guidelines. It's still way down, but anyway, the hope is that this will start to come about. The group at Michigan has done this with dopamine and had really good results. The problem is, as you all know, with dopamine, is it involves a PICC line and a continuous infusion. So we've been trying to use a little bit more midodrine. The other thing we're having to do, and we've done, is to say, okay, let's start using our heart failure medications more, and let's be more aggressive. So we know that Entresto works really well in the adult population. Why aren't we doing it in the pediatric or the congenital population? Fontans are a little bit different, but let's say 2 ventricle patients. And so they finally did this study, which showed, it's no surprise that Entresto improved 6-minute walk. It improved cognitive function and sleep, which I'm convinced did 2 things. I think it improved sleep. I can't prove this, but I think it improved sleep because it helps to decongest patients, so they're not having pulmonary edema and short breath. And I think it improved cognitive function because the patients were less low output and were increasing oxygen to the brain. It's funny that we got asked, ACHA had asked us about enrolling patients in a clinical trial where we would do a randomized control trial, putting our congenital patients on Entresto, and I turned it down simply because we all believe it works and most of our patients are getting started on it now. So I don't think there's any reason. We have enough data from adult 2 ventricle patients from a heart failure model to prove that this drug works and it's safe, to say that we should be at least trying it in all of our 2 ventricle patients. What are we doing about pulmonary hypertension? This is another thing we looked at. So there was a large period of time, right, where more of these congenitals were getting heart-lung transplant, which, in case you missed it, is quite an operation, and the outcomes are not as good as heart alone. So, but we're seeing a lot of these 2 ventricles, specifically the systemic right ventricle patients that have pulmonary hypertension. But is it true pulmonary hypertension, or is it reversible pulmonary hypertension? So we looked at this one patient who had come to Penn, young man who he was congenitally corrected, had presented, as you see in the top line there, his wedge was 33, his output index, he's clearly in shock, and his PVR was 13. So this guy got presented, he needs a heart-lung, and then there was like, well, he's way too sick, we're going to send him home with hospice. And there were a group of us that were like, It's a 30-year-old guy with 2 kids. Like, we can't just send him home with hospital. We got to come up with a different plan. So we started thinking, how do we treat him just like every other heart failure patients that we saw, and got our pulmonary hypertension folks more involved. And what we did was we put him on nitroprusside and dobutamine. And what you'll see is that, as we expected, his cardiac output comes up because he gets decongested and offload. So this was all WHO group 2 left-sided disease that with enough time reverses in a way that we were able to successfully transplant him with a heart alone. Sometimes they come in way too sick. This guy, we were able to try this. This was a woman that came to see me in clinic, came on a Friday. We admitted her on Monday, and then she was VADed the following Friday because she was too sick. But this was a woman who we did HeartMate 3 in for just that sole reason. She was really debilitated and had elevated filling pressures and pulmonary hypertension. That was WHO group 2. So we put a VAD in her, and I'll tell you a little bit more about her story later. Then the other thing is what we're trying to do more of, although insurance makes it difficult, is using Cardiomets. So Cardiomets is a well-proven therapy in adults with heart failure to reduce hospitalizations based on decongestion. So I don't know how often you guys use it in kids, but essentially it just sits in the, there you see it, sits in the PA. We can monitor pressures from home and then adjust diuretics. The first woman we did this in was a CCTGA dextrocardia who had been admitted about every, I don't know, 3 or 4 months. She was being evaluated for transplant, but there were a bunch of barriers. We put a Cardiomets in her, and she hasn't been readmitted in 3 years. She's now getting worse, and we're gonna plan to complete her transplant evaluation now. But it's nice that she hasn't been in the hospital. Sorry. And then we said, when I say we said, Joanne Lindenfeld said to me, the research is really important. I was never that into research. I was into solving problems, and I wanted, and was pretty decent at building teams. And Joanne said, we got to do more research and get this stuff out there for 2 main reasons. One, we'll be able to change how people think about things, and we'll also build collaborations around the country by involving research, because research is a really good way to bring everybody together. So like most things, I do what Joanne tells me. I listen to Marielle, I listen to Tom Bayshore, and now I do what Joanne tells me. So the first thing we looked at was this idea that where should these patients be transplanted, right? Everybody wants to talk about this. So we just said, well, let's just look at it. So we looked at UNOS, and it should be no surprise, right? Low volume transplant centers had worse outcomes in transplanting congenital patients. Now, we looked at this every different way. This has nothing to do with number of congenitals transplanted. This has everything to do with total volume of transplant. Now, I'm not arguing that congenital should be transplanted where there's no congenital surgeons and no ACHD and none of that. But I'm saying that the high volume transplant centers, there's got to be something that we're doing differently. And I think what a lot of it comes down to is this idea of failure to rescue and ability to rescue, in that, like at Vanderbilt right now, we have an intensivist overnight in our ICU. We have a CT surgeon that's available in-house, usually a fellow. So our ability, if something goes wrong, to get someone on ECMO or get them back to the OR is pretty quick, which doesn't exist everywhere. There's this other thing that I have to say I'm guilty of talking about, but Tara had published this, and this idea that, oh, we need to oversize the donors, right? So this idea that congenital patients have pulmonary hypertension that we don't know how to deal with, and we have to oversize the donors because the right heart's going to fail. And so I got to Vanderbilt and I talked to the surgeons. I said, I don't understand this. I'm happy to do it, but why are we doing this? And they said, don't do that. Just get us the best heart that you can get us with a short ischemic time, if we can avoid it. Let's be prepared. Let's get the best hearts and see, which is what got us thinking, like, maybe we've just been saying stuff that's wrong. So we looked at this. Dan Clark, who's I'm still mad at for leaving us. He's now at Stanford, but he's a phenomenal fellow who does MRI. He's now an attending out of Stanford. But we looked at this in UNOS and said, okay, how does sizing matter? And it turns out that undersized, so if you put a small heart in a big body, that doesn't work. Okay, but that's not surprising. But it turns out that if you oversize, so you try to put a bigger heart in just to protect so that the right ventricle doesn't fail, there's no difference in outcomes. And we looked at this based on height, weight, BMI, LV mass ratios, predicted heart mass. We tried every possible thing, and we could not find any benefit to oversize. There's probably small reasons to do it in certain patients. But one of the problems is if you wait for this perfect heart that you really want, you're extending wait times. And the longer we wait to get a heart, the worse the patients get. There's this other idea that we need extra parts. All right, so what does this mean? Our surgical colleagues know exactly what I'm talking about, but everybody else may not. So the idea that the procurement surgeon must be aware of the need to obtain extended donor veins, aorta, and/or pulmonary arteries. And this was a really nicely done state of the art in Jack. And I have to say that I have written that same thing in papers that I've done about we need extra parts. So what does that actually mean? All right, so usually what we do, when I say we, our surgical colleagues do, is they anastomose the pulmonary trunk. So they disconnect. So where you see that black line, they take the donor heart and that's where the cutting occurs. But then the idea is, though, with a Fontan, as you see, right, the pulmonary arteries have all been disconnected and reanastomosed and operated on. So we got to do it differently. So what we got to do is we have to make sure that the donor heart, we get all of the pulmonary arteries all the way out, so that all of that piece can get sewn into the recipient. And now, what does this mean? So this is great, and our surgical colleagues are always happy if we can do this. But this assumes that no one's going to use the lungs. So if the lungs are going somewhere else, then that means that we're having to wait where the lungs get wasted. So our surgical colleagues said to me, don't do this. We'll manage to anastomose and rebuild the pulmonary arteries, just get us the best heart. So again, we looked at this, and it turns out there's no benefit looking at UNOS data in waiting for where you get the pulmonary arteries. So again, wait times. This increases wait times pretty much. Then we decided we're going to see, well, and this is what everyone wants to talk about, that all Fontans are the same. Who needs heart? Who needs liver? This is a talk for a whole different day, which usually involves people getting angry. But when I was at Penn, we published this, that every Fontan that has bridging fibrosis, 100% of them need heart liver. And I was dead set on this, and I thought that was 100% right. The pediatric folks, Dr. Simpson published this from WashU and said, nope, nobody needs heart liver. All the livers get better and they're all fine. So as I will tell you that my data was flawed, this data is also severely flawed because, as we've said, a 13-year-old getting transplant is way different than a 40-year-old, but also we still haven't figured out how we're going to define cirrhosis. So if you look at these 20 who underwent heart transplant that 7 had cirrhosis, that's cirrhosis by CT scan. Only 2 of those had biopsy-proven cirrhosis. So I don't know who's really cirrhosis. And then you see that in this group, some of these patients with cirrhosis died. So were they not put in the right group? I don't know. I'm not knocking this paper any more than I would knock my own paper. And just to say that the answer is sometimes they need dual organ, because what we've seen is when we looked at our explants, Sasha Shingina, who's at Vanderbilt, submitted this. When we looked at our explanted liver compared to biopsy, lo and behold, it doesn't always match. And sometimes we've seen where the biopsy is F3, so bridging fibrosis, and we take it out and it's the rest of the liver is frankly cirrhotic. So what we've had to do is just pretty much say, which is humbling at times, is just to say, we're going to trust our liver team on how they want to evaluate this, and we're not going to hold to any specific rules about who gets heart and who gets liver. Because the other thing that keeps coming up is this idea that liver prevents rejection. And this was shown in the Mayo Clinic did this in 5 patients and says, well, if you put the liver in, they don't reject. These patients were highly desensitized. I mean, if you look, they all got Plex, they all got thymoglobulin, they all got ATG. And when we looked at our data, we've had a number of our heart livers that have rejected early on. And when I get to it, the paper's sitting on my desk that I have to finally submit, but we're going to submit this because I don't think there's a right or wrong, but it's not always the case. And lastly, just to talk about how the whole idea of we changed the listing process for congenitals and said, well, listing is just unfair in adults because look at this, our congenitals in the new system, they're all lumped into 4s and they're going to all die and it's going to be terrible. And Kati and Ari Cedars looked at this and it turns out that that's actually not true. So this new listing system really hasn't negatively impacted us. What it has done though, is it's forced us to change the way we're doing things. And so I won't bore you all with all the details of exception pathways, but Annika Raleigh, who was one of our fellows, looked at this. And what we're seeing is we're writing a lot more exceptions, trying to plead our case to UNOS and to our surrounding areas to say, this Fontan, I know you've got them at a 4, but they're way more sick than a 4. And we need to move them up and we need to get them transplanted. And so far, 100% of the time when we've written an exception for a congenital patient, they've been upgraded on the list. I know this is being recorded, but I'll still say this. I think part of that is that usually my exception starts off with one of the old school pediatric introductions of a full paragraph of anatomy starting at birth. And I think what happens is when they read my exception, they just eyes glaze over and they just stop reading it just to say yes. But in all honesty, I think part of the rule is about exceptions is you have to just make your case and just explain to them that when you have a Fontan that has questionable kidney disease, it's going to need a heart liver that's sensitized, like this is an unstable patient. And then again, this idea that, well, there's no hearts for these patients. And I think, we just have to be aggressive. We talked about at dinner about this a little bit. We're using hepatitis C hearts in our congenital patients. And then this was the first time we did it in a heart liver. And then we're also starting to use DCD hearts, which are donors before brain death, which is a whole different realm of opportunity for these patients. They have no chance of neurologic recovery for those of you that are not transplant savvy. So I want to just now tell you a little bit more about specific patients, because I think this idea of success versus significance is really important. I went to a phenomenal, there was a foundation dinner and Tim Tebow got up there and talked. And we all know him as a football player, but also he's been very, very supportive of the Down syndrome community and as an offshoot for the congenital heart community. And so he talked about, so at this, what he does is every year is that he auctions off his Heisman Trophy for someone to take for 6 months or a year to their house. And he talked about why he does this. And he says, look, yes, it's cool that you can have my Heisman Trophy and you can have it there. But the goal is not for you just to have your Heisman Trophy and say, hey, look at this Heisman Trophy. The goal is for you to have this Heisman Trophy. And when someone says, why do you have this Heisman Trophy? And you say, well, I use that. This came because I donated money to a congenital heart foundation that is doing research for congenital heart kids and helping the Down syndrome community. And so he said, I don't want to be someone whose life is focused on success because success is about us, but significance is about other people. You or we can take our success and turn it into significance. And this has really driven a lot of what we've done and how we think about things. And I think you guys would all agree. So I'll tell you a little bit about success that's not really significant, is that in the 5 years before I came, we had done 2 adults with congenital heart disease. This is what our numbers have done since then. This year alone, in January, we've done 5 congenital transplants at Vanderbilt so far. So overall, we've done 40 transplants, and 5 patients have gotten bad. There's a couple in the hospital that are currently waiting. And I'll just show you this because I know everybody's sort of interested in this miscellaneous category. Are my, I think every congenital person has like a favorite lesion and a least favorite lesion, and I really like taking care of LTGA, and I cannot stand Shohn's anymore because I think and part of that is that I think Shohn's is an underappreciated systemic illness where patients are way more sick than we ever gave them credit to, and a lot of it has to do with their pulmonary function and their pulmonary arterial hypertension. And then we've done the other thing is that Joanne was right about is that we've had some success in terms of research, but mainly the way we've been successful, I think, is that we've worked with a lot of different institutions to build these bridges that have brought the patients in. And we've also included and sort of forced a lot of our fellows to be involved in congenital heart training and research. Because on the adult side, there's only 2 weeks of required congenital heart training in adult cardiology, which to me is crazy. So of all of these fellows and residents that you see here, only 3 of them were actually congenital heart trained or had any interest in congenital heart, which is important because as they go out, we want to make sure that they know something about congenital heart. And so now I'll just show you. So this was our first attempt was James, who we rethought everything, how we're doing things operatively, planning. We put Sean on the right, and we put him on a treadmill every 3 to 6 months. And he's almost 5 years out now. That was when he celebrated his 30th birthday with his son, Mason. He had been told he was never going to get to 30. So this was a big birthday. He's also a quirky dude and had his family make the most disgusting cake anyone has ever had in their entire life. I don't know who ate that, but he's been a big supporter. And what's amazing is that with James, and this is all credit to our surgical colleagues, James, we pretty much emptied the blood bank. 2 units of packed red cells for that operation. Now that's not always the case, but there was a different plan going in. I think we've learned a lot. Pete Huttlinger was a guitarist, very famous guitarist, who was from Nashville. A few years before I got there, he had congenitally corrected transposition, couldn't get transplanted at Vanderbilt because we didn't have the tools, the team. He actually got vatted at Texas. Bud Frazier did it. I don't remember where. No, he's Texas Heart. Which Bud likes to rub in everybody's nose a little bit. But this was something where we learned from Pete, and this is Miss Gomiller on the right, who had exactly the same anatomy. And about 7 years later, she's now undergone transplant. I wish she would stay off the motorcycles, but she's done. We learned a lot from Pete in order to sort of propel forward our ideas and how we could be successful here. The truth is that we're in uncharted territory and we've got to be aggressive about trying new things with patients. And it seems like the patients are into it. So this was Miss Hodge that I told you about. This was a woman, she's this here. She was the woman who was, and I'm sure you guys see this, she was out in the community. Her EP care was being taken care of somewhere between Nashville and Chattanooga. Her EP doc was doing the best he could. He just kept upgrading and changing her pacemaker when needed. And then she showed up in my clinic and I was like, oh my God, this lady looks like she's gonna die. And so this is the woman that I saw on Friday, we brought in on Monday, and because I couldn't convince her to stay. And she was vatted on the following Friday. So these patients are out there. These are like ones that we don't even know. So she underwent VAD, and then she's now almost 3 years. Oh no, she's now 3 years out from transplant. We got this other thing where all of our patients are getting these humongous tattoos to celebrate. It is kind of cool. Of all the things we're going to get angry about, I think we'll leave that one alone. But again, we used what we learned from Mrs. Hodge for Mr. Cochran, who had been sitting in another hospital awaiting transplant for 6 months with really elevated pulmonary pressures. I don't know why exactly. It sounds like they wanted to transplant him, but there was no real clear way to transplant him. So anyway, he came to us. We thought he was too sick for transplant at the time. He underwent VAD, and now he's close to almost a year out. We have a bell that everybody rings when they leave the hospital. So he celebrated now. He's now post-transplant. I think this is something you guys all see, Mr. Burns. I feel fine. I'm doing fine, which we usually say, do you really? But as you guys know, when you've grown up with congenital heart disease, you think you're fine, you just get slower. And we kept putting him on a treadmill. He was a mustard patient that underwent transplant. He's almost a year out now. And then I think one of the things is you got to just be willing to take on certain risks and try to break down barriers. This is Joe here. He just turned 40. He's Down syndrome, unbalanced canal, who was Fontan was done in Philadelphia early on. And he struggled. We learned a lot from Joe, both surgically, but also where we had to go back to the drawing board to say, how are we going to deal with a 40-year-old Down syndrome patient? Because he would have been best served by all pediatric nurses, intensivists, to be honest, not from a medical standpoint, from a psychosocial standpoint. If you want to hear more about his story, he was featured on, they did this documentary. He likes when I tell everybody that he was on television. They did a really nice show on Discovery Health about transplant. But he struggled, as you see, he was on oxygen, needed a trach, and that was him after transplant from Philadelphia. He connected us with the gentleman to his right, was a patient that was also up in Philadelphia on inotropes of Fontan, who needed a heart liver, who was sent home with hospice. Joe's family contacted us and said, you can't let this guy go home on hospice. So he's been transplanted. And now Joe is 2 years out. He's boxing, he's put on weight, and he's doing really well, living his best life in Philadelphia. So what's Camp Menachem? So we've got a bunch of, these are quirky, funny patients, as you know. So there was a period where we had, so Liz on the left, Liz, Camille, and Jen were all Fontans that needed heart liver. Rafi was a Shones that needed heart liver. They were all in the hospital right around the same time. And so they all became friends, and they decided they were going to call this Camp Monaco. Just to clarify, I had nothing to do with this, but this is how they define classmen on campus. But this is an important group for us to look at, because Liz was not our patient. She had come from Ochsner. Tom Young, who was her doctor down there, was one of my mentors going back to med school, who called and said she needs help. Rafi had been sent to us by UCLA. Camille is a really interesting story. He's from Poland. His father was a family medicine doc in Poland. When he was born, they realized that he couldn't be cared for there, so they moved to the States. They were in Kansas. He was sent to us by the University of Kansas, where we have friends. And then Jen is a pediatric cardiac ICU nurse up in DC, who they told her there was nothing to do. And she told me her favorite word is the F word. So she said, I'm going somewhere else. So she came to Vanderbilt. And now this is Jen more than a year out. She said she always makes sure she wants everyone to see her scars, so they ask her what's gone on and hear about her story. This was Liz, who told me that all she wanted to do was try to feel normal. And a year ago, her plan was to climb Red Rocks. And so she's living her best life now. She told me the funniest thing she said, I didn't know that trick-or-treating could be done easily. And I was like, what do you mean? She's like, well, I didn't have to stop and break. Like, I went with all the kids to all the houses. And I was like, wow, we really these congenitals have really learned how to adjust and have a new normal. And then this was Camille, who told us that after all he really wanted to do was be able to hug his daughter. And this was him celebrating Christmas this year with his daughter, who's growing up. And then lastly, one of the best stories we've had is Rafi. So Rafi was in the hospital waiting for transplant. So he was waiting for heart liver as a Shones. He had pulmonary hypertension, we could not keep him dry no matter what we did. He was very diuretic resistant, so needed IV diuretic. So he was in the hospital about 3 months waiting for transplant. Got to know all of the nurses who all became part of his family, and he proposed to his now as a fiance on the day of his discharge. So that was quite something. He's getting married in July. So just to conclude, I think how do we change this paradigm, and what are some of the keys to success, at least in my mind, is one is we got to get to these patients sooner. And I think we make a big mistake to put up any barriers to referral. I tell everyone, just send me the patients whenever you want. And me saying you don't need a transplant now is not a bad thing. And I'm happy to see them. And I think we have to do more of that. I think we have to do a better job, especially on the adult side. I think as pediatric teams are better at this, but we have to come up with a better collaborative treatment option. We got to stop just saying stuff, and we just say stuff and get up and, oversized donors and all of this. We don't know if it's actually true. And I think we've got to do a much better job of demanding data and looking at those studies. And the truth is it's there. Just takes a little more effort. We have to try new and unproven techniques. These DCD hearts, hepatitis C, we got a lot of pushback. How can you do this in congenital patients? And the best part is that, like I told you early on with James, is that the patients and the families, to be honest, they want to be the first of anything new. So if they're on board, I don't know what's holding us back. And then I think always, and I think this is really probably more important for residents and fellows to think about, is that, what we do can be a grind, especially when you're here all the time. But I think sometimes you got to stop and think about the significance of what we're actually doing, because we are getting to make meaningful differences in the lives of a number of different patients. And with that, I will end, and I'm happy to answer any questions or your comments. I see a lot of people writing in the front row. I don't know what that is.
So Dave Velez, who's our chief surgeon.
Oh,
I'm sure he'll start out with an easy question.
I share some duties also with Wayne. So first of all, thank you for accepting his invitation. It's obvious that you have achieved more than success and definitely significance. Taking this pathway in training and allowing all these mentors, some of which I've gotten to know this week, share some path. It wasn't, I'm sure it wasn't easy, just that even though you knew there was light at the end of the tunnel, but probably you couldn't see it at the beginning. I have some comments for you to potentially elaborate, and then one actually specific question.
Sure.
I'm curious as to what is the composition of your surgical team, your location?
Mm-hmm.
What are the responsibilities, not only procuring, because I agree with you, delaying, and we do that in a stratified fashion. If the patient is doing okay, I'd rather wait to have native tissue to bring that
Yep.
away. Particularly when I think of adult congenital transplant and embarking on that. If I'm not the one driving, it's very hard to operate through somebody else's hands to elaborate a batch in three-dimensional fashion that they're not used to. The best thing that an adult guy, and I don't mean this in disrespect can do or does, is actually putting two big circles or anyone together. They're not thinking about baffles, the LPA, and so on, how to create those patches. So we mitigate that also by, when we have to do it, we bring the donor pericardium when we use that for reconstruction. So I'm curious after the composition. The current team, by the way, I'm very surprised that somebody took a shot at doing single ventricle downs, because that's not the norm, right? But also, I want to comment that I still see the liver as a crazy black box, because you think you can make the call before they got to the cliff, but as soon as you get into the operating room, that's the cliff.
Yeah.
And I can see how we just think that the function of the liver or the synthetic function is okay, and then we're opposed to that of every fault. Now, granted, we also found ways to be ahead of that and somewhat, I was somewhat successful in surgical field to do that. And then lastly, I'll ask you to see if you can share with the team here, what are your measures, preoperative measures to deal with invasive lesion? It seems that we can connect, we can take advantage of hypotension as one of the tools to mitigate bleeding, control hypotension. But boy, I mean, it can be very, very challenging to care for these patients. And then when they do ICU, pressure, water,
Yeah.
et cetera, we counterproductive
Yeah.
organ function. So just those 5 or 6.
Yeah, so let me try to hit all of them. So we do all of these transplants at the adult center. I mean, Vanderbilt is a little bit different than you guys, so we're connected. It's one hospital system. But our ICU, they see last year we did 123 adult transplants. So like our ICU team is used to seeing transplants. So that's our surgical team is almost always, so I required that our congenital surgeon and our adult transplant surgeon to review the cases beforehand. I'm sort of forced to make everybody work together sometimes, which is not the easiest, although they always do like operating together. Almost, so every Fontan has been done by our adult transplant surgeon and a congenital surgeon. There have been 1 or 2, like a tetralogy that's been done by one of our senior adult transplant surgeons, but there's always discussions about who's going to do what. To be fair, our most senior transplant surgeon, I mean, Asha has been doing this for 25 years and was also a lung transplant surgeon. So like, if any of our juniors, I told you, if any of our junior surgeons are going to be involved, then on the transplant side, then absolutely our congenital surgeons are involved. Okay. So I think all these patients benefit from more views. That was question number 1. Question number 2 about the liver. We don't know. I think we're doing all of the testing. I think the CT scans aren't super helpful, except where they've looked when the patients have a lot of varices or have recannulation of a like umbilical vein or something. We've said, okay, they're frankly cirrhotic. We should be doing heart liver. We're doing biopsies on everybody just to sort of match things up. I think elastography, I don't think it's worth anything, to be honest. We're doing it just to see. But I think the other thing is that really age plays a big role. It's tough to imagine that a 40-year-old who's had a Fontan circulation for 40 years is not, their liver's okay. But we did do a 40-year-old that we did a heart alone and she did fine. So there's a lot of back and forth. It's no easy answer. I don't know how to deal with the hypotension. I don't think any of us do. I think what we've done well, though, is we've been more aggressive about putting patients on ECMO post if we think there's going to be bleeding issues or hypotension, which I know is not always an indication for ECMO. But what we're finding is that, as you know, like if you do the heart transplant and then the kidneys start to go and then their lungs start to get congested, then we wind up with more problems than we started with. So the hypotension, I think we do all the things that you guys probably do, but we're trying to be more aggressive on supporting the rest of the body along. And then in terms of your question about Down syndrome is a very good one. No, I don't think there's that many of these patients. I think he was turned down by a fair number of centers who were concerned that he was Down syndrome. I didn't think that was a fair reason to turn him down. He had other reasons that centers turned him down too. But I think if we were going to do that again, we'd have to rethink the training and who was going to take care of the patient. I think I got most of this.
So 2 specific questions.
Yeah.
So one was pertaining to the metabolic.
Yeah.
When you put these spontaneous patients with PLV, do you start them as now you started protocol and how long before you see the effect? And is it somewhere related to this planting workflow, or does it also decrease your spontaneous patients?
Can I just say yes? We're not really sure. I think I think probably some of it is decongestion. Also, you probably increase forward flow to the kidneys. They're diuretic, they become less diuretic resistant. Most of our patients are getting put on Midodrine now, and it's varied. We have some patients we put them on 5 of Midodrine TID, and they start doing great. Then there's some that have to get up to 20 before, and then there's some patients. We have one patient in the hospital, he had no response, and I have no idea who's responding and who's not, like how to judge up front. I do think the other thing though we've seen, and we used it in our Down syndrome patient, Midodrine, he didn't have PLE, but he was having a lot of ascites and pleural effusions, and it does help in those cases too, to sort of, he was on oxygen before we put him on Midodrine, and then came off because his pleural effusions sort of started to go away. I think some of it is, it's like magical thinking with Midodrine, but it does seem to benefit the patients.
And my second question was regarding the use of microbicide and Lovitin in patients who have high capital pressure.
Yeah.
How long before you see the decrease in the pressure?
Yeah. Well, so if their pressures will tolerate it, right? When we're in the cath lab, if we put them on high enough doses of nipride, they should vasodilate enough that you can drop their wedge acutely. Now, the problem with that method, right, is that that's only transient. So I think I think that usually gives us a sense of who's going to respond. In the gentleman, we did that for 37 days. We don't typically do that. There was no interest at Penn in VADing that patient. Now, looking back, if he came in now, I would probably push to VAD him, because there's really good data that if you decongest patients with cardiomyopathy with VAD, that their pulmonary pressures will remodel. So I think we should get an early signal that they're what type of pulmonary hypertension they have. And in fact, the group in Gatsoulis in Europe published this, that over 90% of our systemic right ventricle patients that have pulmonary hypertension, it's WHO group 2, so post-capillary pulmonary hypertension that reverses. Oh, thanks.
If I was allowed to pull it a couple of times.
If you're allowed to what?
Pull.
Oh,
I mean, like the PLD stuff. I curse the PH, say it's not a risk factor. Of course, I don't want to, but, one of the things that I was before you do is to improve the adult granular data on congenital heart disease. Because writing papers for CPRD, you're not able to tell us with good data about all of these things that you're learning.
Yeah.
It's true that PLE over time is dramatically different to the PLE change. We see it as eating.
Yeah.
It's a big problem. And the other thing I say, I hope you have a really big team, because the reason you're exceptionally questioned is that none of your colleagues want to do this. So they're all static that you take this on. People don't realize that 40% of our pediatric patients are presented about 3% of the world. You spread that out over all the adult programs. Nobody is really clear. And so it's just a great thing to be taking this on for that whole population in the country. But eventually, with this research, doing things like this, you're going to have to teach everybody else how to have this all-in approach to excellence.
I wish more people would do it, because it's problematic, not just for, we love what we do, but these patients that I'm showing you, like, they have to move to Nashville, and it changes their whole, they have kids, they have families, so we need to have other centers of excellence that are willing to undertake this sort of.
Past time now. I think it was a phenomenal talk and some great questions. I think we all learned a lot. Thank you again
for having
My question from that is
Yes.
All right. Like how you said about. I don't get referrals until they're already in trouble.
Thanks.
Sorry, I can't stand there.
No, it's okay.
He's a Duke guy. He's used to a threat. Joe and Anne-Marie were.
Is that right?
Oh,
wow.
With Anne-Marie day before yesterday. Joe too.
Yeah.
Yeah. We both were, we three were, they both were doing adult, I was doing all the clinical care policies, so we were all.